All right, everyone. So we're going to do a little in-service on ultrasound-guided peripheral IV placement, specifically the long-axis view, which we feel is superior for a multitude of reasons. This is kind of a hybrid technique between short-axis and long-axis views. The rationale for emphasizing long-axis view is that it's much less likely to cause damage to the vein by virtue of being able to see the entire IV needle and catheter coming in, as well as the vein. We're able to make sure that we're not going through the left or right side of the vein or the back side of the vein, thereby causing a hematoma or causing inflammation and potentially thrombophlebitis. So with the long axis view, as we'll demonstrate, it's much easier to see the whole needle and make out the tip of the needle exactly, whereas in short axis view, sometimes you could be confused about whether you're actually seeing the tip of the needle, and then you have the risk of going past the vein and hitting other anatomical features that you do not want to hit, for example, arteries or nerves. The other advantage of a long axis view is that you can make out the caliber of the IV catheter relative to the vein and make sure that the catheter fits well in the vein. Again, reducing the risk of clot as well as irritating the endothelium and causing any kind of irritation or inflammation. Just a few other quick points before we get going. We use the following terms interchangeably. So short axis, transverse view, and cross view all refer to the same thing, which is a more cross-sectional view of the vein, whereas a longitudinal view or long axis view is looking at the vein lengthwise. Now, obtaining the long axis view is much more challenging, but well worth the effort for the reasons that we just explained. And so it's a very thin beam, ultrasonic beam, and so maintaining a long axis view requires more coordination in multiple dimensions, whether it's to left or right, tilt, or having the ultrasound beam up and down the arm to align with the vein properly. So it is a more challenging view to obtain, but we'll show you a few tricks in terms of how to keep that view stable and be more successful in achieving the long axis view. Eventually, the investment in time getting more coordinated in doing the long axis view is absolutely worth the effort. Now, it's also another key point is that because it's a little bit more complex hand-eye coordination effort, it's very natural to exert too much pressure on the vein as well, because you're so focused on getting that correct view that you can compress the vein. So keep that in mind. And what we'll talk about initially is getting a short axis view, and then we'll be switching to a long axis view, as we'll describe next, thanks to Nancy and Wendy. Okay, so this component is in terms of organizing the space and positioning the patient. So I think a couple of tricks. It's good, as Nancy is positioned here a little bit more towards the right side of the bed. It makes it a lot easier to have the arm be in a position that's sustainable. That's one of the keys, is if the arm is hanging off the bed more so, it's hard for that patient to maintain that position for a long time, and that's an issue given the difficulty of the long axis view, why it's critical to keep the arm stable and your hand stable. So that's why we've got her positioned over to the right a little bit so she can lay her arm down more easily on the bed. You also notice that we have a nice towel or chucks sort of laid out, because with the technique that we're going to show you, it can get a little bit messy, and it's also important, again, for patient comfort to have enough padding underneath her arm, so you could even add a couple towels underneath there, and that way it's just much easier for the patient to be able to keep that arm in that position for a long period of time. The other key is, where is the ultrasound going to be located? That's individual preference. In this case, Wendy has it located right next to her, but you can also keep the ultrasound across from you on the other side of the patient. So it's going to depend on which arm you're using, what the configuration of the room is, what the bed is, bed location is relative to the room, what space you have on either side of the bed. as well as what you're comfortable with. What angle are you going to take? So keep that in mind, that you can have a little bit different orientation of the ultrasound itself depending on whether you are approaching from the right side of the patient or the left side of the patient and what space you have within the room. Other things that we have here, we've got things ready to go. We've got the lidocaine ready to go, the syringe to draw that up. We've got the tourniquet, of course. In sequence, you're going to be applying the tourniquet, and then you're going to apply gel to the ultrasound, get a good view, then use some ChloraPrep to clean the space where you're going to insert and inject the local anesthesia, as well as ultimately the IV catheter. In this case, we've got a 20 gauge long catheter. It is important to have a long catheter, long needle, because by the time the needle shows up on the ultrasound screen, you don't want to run out of catheter by the time you get intraluminal, so that's very important. Other things that are important to have ready is you've got your J-loop, you've got your IV flushes, and you've got your securing device, whether it's a stabilization device or tape and Tegaderm. Have everything ready to go. This is a two-person endeavor because you're going to want to keep, especially if it's a patient with a difficult to place IV, it's going to be critical for you to keep that ultrasound image stable, and then once you get the catheter intraluminal, it's important for you to still hang on to it. Let the other person help you with attaching the IV setup to the IV catheter. So then the next step, so we've got the patient organized in terms of location on the bed, we've got our space organized in terms of where you are sitting, where the ultrasound is positioned. The next step then is to get our supplies organized. So starting with the IV catheter, one trick here is that as we said, we want to use a long catheter, but we also want to remove the back of that, the stopper, because that allows continuous free flow. Problem is, if you're having to do a little bit of manipulation, you're not quite in the vein, or you were in the vein briefly, but then you're not certain. If you don't have the stopper removed, you don't achieve continuous free flow. The downside of that is it's going to be a little bit more messy when you have continuous free flow of the blood from the back of the IV catheter. So that's why it's important to have the towels laid out the way we do. So once you've got that organized and ready to go, then we can apply the tourniquet. And you've got your vein diagram in your packet showing you the difference between the cephalic and the basilic systems. We're going to try to go for the cephalic system if possible, leaving the basilic system for PICC lines, etc., if necessary. And once we identify the vein, we'll go from there. So go ahead and apply the ultrasound. In the meantime, we also had the lidocaine drawn up in a TV syringe. We have our ChloraPrep pads ready to go. We've got our J-loop flushed and ready to go, as well as some gauze pads in case we need those, and a stabilization device. So those are all standard IV placement tools, perhaps with the exception of the IV lidocaine, or the lidocaine being drawn up in a TV syringe. So go ahead, Wendy, and apply the ultrasound. So we're going to look initially in short axis. Now you can start by looking closer to the antecubital fossa, that's fine, but our goal is going to be to move down the arm as much as possible for a couple reasons. One is, if you get a hematoma further up the arm, then you've lost that whole territory. That whole vein can no longer be used, because then you're going to have extravasation further upstream. And so what we're going to do is we're going to find a good vein in short axis view, and Wendy's got one there, and right now we're at approximately 2 centimeters depth. So another key to this is going to be to identify what is your depth on the screen. So I don't know if we can zoom in on the screen. So when we change, there's two things that we're going to change. We're going to change the gain to make sure you get enough brightness but not too much washout, and you're also going to change the depth. So if we maximum depth, for example here, you've got a 4 centimeter scale, so that means each of these is a centimeter marking. Looking here, that's the vein that we're identifying. The advantage of looking at a more zoomed out, if you will, view is that you can identify more candidate veins in this view. But the problem is the resolution is not as good at this depth. So once we've identified a vein that we like, then we're going to zoom in, because the better zoomed in, and this is a 2 centimeter scale, so this is going to allow us to have better resolution, especially in the long axis view. So once we've identified the candidate, so initially you adjust the gain so you can see it well, and then you're going to adjust the depth, zoomed out first, and then zoom in on your target, which is right there. And so then what Wendy's going to do is start following that down the arm, and this is very important. The trick is to keep the vein in the middle of the screen as you go down. That's going to give you a lot of information, because what does it take for you to keep that vein in the middle? If you're able to go straight down the arm with the transducer, as Wendy is doing right now, then you know the vein is straight and it's going straight down the arm. So there's 2 criteria. One is the straightness of the vein, so this can be easy to catheterize, but also how is the vein traveling in the arm, because that's going to tell you the angle that you need for the transducer in long axis view. Once she turns it, she's going to know where to turn the transducer so that it follows the vein and it's easier to acquire a long axis view, and also how the needle is going to be positioned as you insert it. So this vein, it's if we relax a little bit on the transducer, so that's another thing to keep in mind. It's very easy to apply a little too much pressure, in which case you're not going to have an accurate assessment of the depth of the vein. So in this case, once Wendy relaxed, you can see that the vein is just short of a centimeter, probably in the 3/4 of a centimeter depth in terms of the center of the lumen of the vein. The other thing that Wendy was showing you is that pushing down on the vein, so this is also very critical. Notice how it's circular, easily compressible, and non-pulsatile. So those are critical criteria to make sure that this is not an artery that we're looking at. So easy compressibility, larger, circular, as well as non-pulsatile. So go ahead and compress that vein again, Wendy. And that's good. And it's also good to make sure there are no arteries nearby. So I think we have a really good vein identified, and we're able to continue to follow it down, down, down. What you'll notice as you go further down the arm, sometimes the vein will dive down, but then it'll become more superficial further down the forearm. So at this point, as Nancy or Wendy is getting closer to the edge, the side of the arm, the more lateral aspect of the arm, it's going to be harder to keep the transducer in a stable position for the long axis view when you get to the side of the arm. So we want to be a little bit further up the arm, and that way when she turns the transducer, she's able to keep that position without slipping off the arm to the side of the arm. So this seems to be a perfect location. And so now Wendy's going to demonstrate how she acquires the long axis view. Now one of the other keys before we do that, Wendy, is point out the notch on the ultrasound, so if you could pull away from that. So there's a notch on the side of the ultrasound, and that corresponds to the green dot on the screen, which in this case is in the upper left. So it's important to get that oriented left to left, because that way if you're moving the transducer to the left, if you could try that, Wendy, go to the left, that way we know we're actually on the screen corresponds to left in the patient's arm. If we move to the right, there's the vein again. We know that right is right because the notch on the transducer corresponds to the green dot on the upper left of the monitor. So that's an important orientation. Similarly, once you switch to long axis view, you need to, and you can go ahead and start doing that, it's critical to make sure the notch is down, facing you as the IV placer, because then once we get in long axis view, we know the needle is going to be coming in from the upper left going to the bottom right. You don't want to get confused and have it coming from the opposite side. So have consistent location of that notch so it's down. Furthermore, if you've got a nice ultrasound like this, you can actually see the blood moving from left to right. And that's an indication, in this case, that the blood is moving away from Wendy, which means that this is another confirmation of being a vein, which is a pretty cool confirmation and tool. That's how good our ultrasounds are getting, which is really great. So here Wendy's acquired a perfect long axis view, and now again she can confirm. Again, if you noted in your mind what the depth of the vein was, it was around the 1/2 to 3/4 centimeter mark, and again that's where this one is. So that's the same vein that we were looking at in short axis. That's a confirmation because it's exactly at the same depth as the one in short axis view. We also have the blood moving from left to right, so that's a vein. And then again, she's going to do a compression and confirm, yes, it's indeed the same quality. It's readily compressible. So we've got a really great target identified. Now you notice what Wendy is doing in terms of stabilizing. So she's using the left side of her hand to kind of also stabilize her whole left hand. So you can either use just your pinky or you can use your whole hand. Whatever technique is comfortable for you, use that to stabilize the hand. The other thing you can do is you can put your feet up, if you could try putting your foot up on this wheel there, Wendy, and then rest your elbow. She can rest her elbow either on the bed or her leg. That will allow even further stabilization. So stabilize the hand and stabilize your whole arm in order to maintain this very solid image here and make sure it's a stable image throughout the placement. So that's a critical feature of this, because it's a very narrow beam, it's very easy to lose this view. Wendy's making it look a lot easier than it actually is, but she's got a lot of skill in keeping that view stable. And the trick is to keep it stable throughout. So we're going to do another explanation or demonstrate another approach to acquiring that same view. That way, when you first learn how to do this procedure, you may need to use both hands in order to acquire the view. As you become more skilled, it'll be easier to do it with just one hand. Furthermore, we're going to show the acquisition of the view without Wendy's hand in the way, which may not be natural for you. So if you are right hand dominant in this case, which Wendy is in this case, you're going to use your left hand to hold the ultrasound and acquire the view, and obviously the opposite if you are left hand dominant. So typically Wendy's going to acquire the view with her left hand, but in this case she's going to demonstrate a couple things. One is that you may use both hands initially when you're first learning how to do this to acquire the view, and secondly she's going to actually remove her left hand in order for you to see the motion that she takes as she goes from short axis transitioning to long axis. So go ahead and start shifting, and you can see again the notch and the ultrasound is going to be facing down, because, especially in this instance, because the green dot is in the upper left. Now she acquires that view, and that's the process. Now, because you can see that the transducer is sort of pointing in that direction, it's not straight up the arm, but it's in this direction. That's important to note also, because then when you insert the IV, it's going to be, it needs to line up exactly with the transducer in order for the needle and catheter to appear on the screen going right in on the vein. So that's critical. So another concept that, speaking of, the whole emphasis of this last section has been how to stabilize the view. Another key point that someone made is this cord can get quite heavy, so there are various techniques that you can use to just take the weight off that cord. You find whatever technique works for you, but that's important to have enough slack as well as have something else holding it so there isn't as much weight on your transducer. Because that view is so unstable, it's so easy to lose that view, you want to have everything working in your favor to maintain that view. So Wendy's got the long axis view, and we're going to go ahead and start preparing the area. So we use a washcloth, and we didn't mention that earlier, but having a washcloth is also very handy. It's much easier to wipe gel with that rather than using multiple gauzes. And then we're going to have her assistant will help hand off the ChloraPrep. We're going to go ahead and clean this area thoroughly. And then we're going to go ahead and get the TB syringe of local anesthetic. And so she's going to go ahead, and one of the keys here is to inject it as close to the probe as possible, but again, you want to keep it in the clean area. And so we give the patient a little warning, take a big deep breath in,
So you're going to feel a pull.
big deep breath in and a big deep breath out just to cool down, and then she goes ahead and inserts, injects.
Burn, 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 burn.
And because that vein is a good 1/2 to 3/4 centimeter below, it's no problem injecting all this local anesthesia and making her as comfortable as possible. And then I let them know that subsequently you should only feel pressure, that we want to confirm that this localization has worked, and reassure them that now from this point forward it should be mostly pressure, except potentially when we get close to the vein or artery, if we're actually trying to cannulate the artery, that there may be a little bit of discomfort there. They should brace themselves, because if they're not prepared for that, what can happen is the patient will jump because they didn't expect anything, and then you've lost your view and you've lost all your preparation. So at this point then, the local works very quickly, and we're going to get the IV catheter handed off. This is a long 20 gauge, and we've removed the back, so we have continuous free flow. And we're going to go ahead and confirm as we insert the needle. We're going to make sure that it's going exactly aligned with the transducer. So you can see in this case that the transducer is slightly pointed sort of bottom right to upper left. It's not straight up the arm per se. And so then when Wendy comes in with the IV catheter, go ahead and inserts, it's going to have to be aligned exactly with the transducer. So we can zoom out there a little bit and see how what the IV catheter looks like. Perfect. And that's aligned exactly with the transducer. And we've confirmed, yes, that we are comfortable right now with that insertion. Yes, the patient is happy. The other point that we wanted to emphasize is notice where the IV is inserting relative to the ultrasound probe. So you've got the mark in the middle of the probe that represents the two plastic pieces coming together. That's the middle of the probe. Typically, the ultrasound beam is going to be slightly off the middle. You need to learn how your ultrasound works, so that in this case, for example, we insert a good couple millimeters to the right of that that center point, or the center notch of the ultrasound probe. So that's one trick also, is are you going to insert right on the middle or slightly to the right of middle of the notch on the probe. So now we're going to focus on the screen. So we've got the IV catheter and needle inserted in the skin, and we want to make sure, this is a really critical point, that you identify the tip, which you can see here, as quickly as possible. Because if you don't identify the tip, you should not be inserting more than about 1/2 centimeter. Otherwise, the risk is that you can overshoot the vein before you know it and hit other parts of the anatomy that you don't want to hit, like nerves and arteries. And so here you see that we've got the tip identified right away. It's very clear. And then we've got a nice view simultaneously of the vein and the tip of the needle identified quite shallow. So that's great. If you do not see the tip, it's also important to move the ultrasound to the left and to the right until you identify the needle. It's most critical to identify the needle first, more so than the vein. You always want to know where the needle and the tip of the needle is, so you don't do any damage and you don't over insert. And then if you are not lined up, then you can, once you move to the left or to the right, then you know where the needle is relative to the vein, and then you can adjust the angle of the needle to the left or to the right to compensate for that. So now, right now, we've got a great view where we can see the tip of the needle and we can see the vein simultaneously. So that means that needle is coming in exactly aligned with the vein. So we're going to go ahead and insert. And before you insert too much further, Wendy, important also to note what the depth is, because you don't want to reach the target too much to the right of the screen, otherwise you're going to run out of screen to view the needle actually and catheter inserted into the lumen of the vein, and B, or secondly, you're going to run out of catheter, so that there's too much risk of the catheter coming out of the vein. So you want to have plenty of run length for the catheter to be inserted into the lumen of the vein, where there's a risk of being dislodged later on. And so because this vein is a little bit deeper, it's going to be important to take a little bit more of a deeper angle, a more acute angle. So I know sometimes people talk about a 45 or 60 degree angle as a standard. I don't agree with that. I think it depends on the depth of the vein, because ultimately you want to come in on a fairly shallow angle because it's a lot easier to thread the catheter. If it's a deeper vein, you're going to have to take a deeper angle in order to get into the lumen closer to the middle of the screen. So go ahead and start inserting further. So Wendy's moving nice and slowly here. You can still completely make out the tip because it's got this triangular look. It's got a nose, and you've got the whole. Now she's in the lumen, and she's going to, but the catheter isn't quite in there, so now she's fully in there with the needle and the catheter. So in this case, we're still not getting flashback. So Wendy's going to pull back a little bit. And what she can do is move the ultrasound to the left or to the right to see if the IV catheter is... I would move the ultrasound to the left or to the right. That way. So when she moved to the left, she was able to see the needle better. So that means the needle was to the right of the vein. She's going to adjust the angle. Now she's going to reinsert. Right, so in this case she did not get flash, and so she's going to angle to the right. Come on back and angle to the right. Go ahead now, insert. Should feel a pop. Now sometimes you don't get a flash, but you are quite convinced that you're in the vein, and then you may not get the flash either because there's some obstruction at the tip of the needle, for example, or a little bit of a clot at the tip of the needle. You can advance the catheter, and then you get flash through the catheter. So if you really are convinced that you're in, then don't hesitate to try threading the catheter. If it threads easily, you'll get free flow at that point, and then you know you're there. Again, we have the triangular tip of the needle here, a nice view of the vein. We're going to go ahead and insert. You should feel a little pop. Warn the patient that they may feel a little something so that they don't jump, otherwise they'll lose the view. Now notice that you're actually not deviating. Actually you've got, go ahead, yep, we're good with the catheter, intraluminal. We'll just advance the catheter, then you can set the ultrasound down and then just advance the catheter. Take the tourniquet off. So now you can see that we have really good blood return. We're going to go ahead and compress upstream. You can stop that. And then go ahead and attach. And then the rest of the securing procedure is standard IV securing process. Be very careful about the ultrasound as well. Notice how Wendy laid it on the bed. It's very easy to drop the ultrasound and damage it. Also, Wendy confirmed that she's intraluminal by drawing back and got good blood return and flushed. And this is where you can also confirm that you're not having any pain in the arm, no swelling. Get confirmation from the patient. Sometimes you'll have a little salty taste in their mouth as well, confirming that the cold solution goes up the arm, and then also a little bit of a saline taste in the mouth, and that's a good confirmation that you are also intraluminal.